welcome to my channel. So today I'm going to talk you through endodontic treatment of two of one, that is right center incisor, where RCT was done in two appointments. And in this particular appointment, the apex area, MTA barrier was placed, and finally root canal treatment was completed. So I'll be starting the video. After local anesthesia is given to the patient, we start with rubber dam isolation. And as you can see, the rubber dam is being placed here. Since this specific tooth was already treated, uh, the access here was made through the incisal edge. We are using a floss so that the rubber dam passes through the contact in between the incisors. We perform the leak test to see whether there's any leakage present in the rubber dam system that we have placed. Since this was the second visit of the patient, a temporary was given on the first appointment, which will be removed. This is a very important clinical step. Our main goal here is to remove the cotton plug or a Teflon plug and to check and examine whether the canals are dry or not. So here we have got dry canals, hence we can move on to our next step, that is placement of MTA and obturation of this canal. So sometimes when the patient comes back after say 10 to 12 days after calcium hydroxide placement, in most of the cases the calcium hydroxide is becomes hard inside the canal, and it is very important in such cases that we remove the calcium hydroxide well. So these next few steps, I'll be removing the calcium hydroxide from the canals. I'll be putting in liquid EDT, I'll be putting in hypo, I'll be activating them with the help of sonic and ultrasonic devices. I'll be recapitulating the canal with my master file so that the entire calcium hydroxide is out. Plus, we can also do a little bit of more cleaning here. Here I'm also making sure that the rotary file is brushing along the sides of the canal. So it will help me to clear out whatever debris is there inside it. So every time we irrigate the canal with either saline or hypo, we have to make sure whether the color is not white. That is, it doesn't contain any debris or calcium hydroxide inside it. So ultrasonic device is being now used to activate hypo. I think this is my last wash of hypo. I generally do 3 cycles of hypo activation before I proceed to obturation of the canal. So I've now moved towards the process where I'm going to take an X-ray. A master cone check is being conducted here, and the recommended method is that one needs to remove the frame and the rubber dam sheet and place the sensor behind the tooth where the RCT is being performed. But I tend to push my sensor through the dam itself, since the dams which I use have good flexibility, good stretchability. So I don't need to remove the entire assembly. I just need to push my sensor through the dam and get the extra dam. And one more thing which I've done here is that I had flushed the entire canal with hypo, then I put my master cone inside it. So by the time I take an X-ray, the master cone is washed with the hypo and gets disinfected. This is one technique by which one can disinfect the GP while working. It saves time. After my activation, agitation, and entire process of irrigation is done, I'll be drying the canals with paper points. After this step, I'll be shifting to the step of mixing of MTA and placing it inside. The initial placement of the MTA will be through the master cone itself. Then I'll be pushing it to the apical end of the tooth with the help of specific pluggers. MTA being placed inside the canal. Now, the MTA, it has a tendency to stick to the walls of the canal. So one has to cleverly manipulate it towards the apical end. Once I've pushed a good amount of MTA into the pulp chamber, I'll be pushing it down towards the apex with the help of carefully selected pluggers. I had shared a video about where an abscess is being drained through the IND method, and it was the same case. This patient had presented with a huge abscess. I've shared the video in my channel. You can go and have a look. The presentation of the case. On the first day itself, LA was administered, local anesthesia was given to the patient, then incision drainage was done through the microscope, after which I had made an axis and did the initial biomechanical preparation, given calcium hydroxide and left the patient. The patient was recalled after 10 days, and I have started this procedure which I am demonstrating in front of you. So now I put the bioceramic sealer and the master cone that goes in. The extra of GP being removed. I'll be using a down pack instrument to remove the GP and pushing the GP beyond the CEG area. So main goal is to remove whatever GP is there inside the pulp chamber. You have to remove it completely. Now hot GP condenser being used to shear off the GP on the chamber. So here I'm removing the extra sealer from the walls of the chamber by using a scaler and inspecting whether any sealer is there or not, or whether GP is sticking onto the walls of the bulb chamber. And then I'll be using either a DG probe 16 or I'll be using an excavator to remove the extra GP from the walls of the chamber. After I'm happy with the obturation, I'll be shifting my focus to a proper build-up. See, excavator is being used to take extra GP out from the walls of the chamber. This is a light curable uh, glass iono cement which I'm placing inside the chamber. Bonding agent will be applied next. After the application of bonding agent is done, it will be cured, and then flowable composite will be used to do a gross build-up. Since the neighboring tooth is also treated, but it doesn't require root canal, composite build-up will be needed in the next appointment. So I'll be finishing both the composites in my next appointment on both the central incisors. So gross build-up was done, and finally the patient was left. I'll be also sharing an X-ray of the post-obturation in this case with you. Thank you. Please like, share, and subscribe to my channel if you want more such content. Thank you.